Hello.
Hello. Hello. Hello. Hello. Hello.
टेलीफोन में चार्ज करता है। टेलीफोन में एक लिंक भेजो, उसमें खोल के देखो। एक बार लिंक खोल के हो रहा है क्या? क्या नेटवर्क इशू है?
Hello.
Good morning and Jai Hind to everyone on this special day. I welcome each and everyone, those who gather here to this So it was a special day in this 13th weeks, the series of alumni of our college. So everybody knows that Panadima Subhadi Nursing College is a constituent college of Swami Vivekananda Subhadi University, Meerut. Have this more than 260 acres land where widespread of knowledge is being shared with different sources of knowledge and different streams of subjects. So as a part of it, we are very glad to have eminent speaker today, Captain Neha Tomar. She is the alumni of our institution. She has completed her BSc in the year 2013 and her MSc in the year 2016. Always we feel proud that our army is doing great things protecting our country from other outsourcers. So as our alumni, she joins in army and she is in the rank of captain and she serves the people of needy. So it's our honor to have Captain Neha Tomar, a proud moment for our Subhadi Nursing College that our alumni is a captain in army. So we welcome you, ma'am, on this day as she is going to speak about PPH. It will be a good session to each and everyone, those who ever watched this. Please have interaction session. Students can ask questions to her, or you can type the questions in the chat box so that we can communicate her what are the doubts that we can ask to her. So at this moment, I welcome Captain Neha Tomar to take the screen, and you can share your thoughts and ideas the to the participants. Welcome you, ma'am. Ma'am, please unmute your mic.
Hello. Good morning, dear students. I hope you know me. I was a student like you. So, sir has told a little bit about me to you, so no need to introduce myself. And today we are going to discuss about PPH. Okay, later on I'll tell you about military nursing services also. So don't worry, have patience, and we will discuss first about the PPH as it is a alumni SP. So I must speak on a subject in which I have done my masters. Okay, so our objectives under which headings we are going to complete the topic are definition, risk factors, causes, diagnosis, and management. As all of you know that it's a condition when a woman get killed or murdered Okay, because of sometime it is a fault of the institution level, or sometime it's a fault. It can't be said as a fault, but there are some disease conditions which are underlying and cause the maternal death. So, hemorrhage is a huge blood loss and cause hypovolemia to the person, wherever it is. But when it comes to gynecology or obstetrics, so it is PPH, means postpartum hemorrhage. Hemorrhage is two types in obstetrics. One is antenatal and one is postnatal. So we are going to discuss about antenatal hemorrhage. Next slide, please. Next slide, please. So, as I said, that it can kill a woman with it or with the complications caused by the hemorrhage. Next slide, please. So, I hope you must have like idea what is hemorrhage and what is PPH. So, it is a leading cause of maternal death in industrialized nation before the Second World War, and after that also it is continued as same. Next slide, please. So, how we will calculate that it is a hemorrhage? Sometimes it is said that if we lose 500 ml blood in vaginal deliveries and 1000 ml blood in cesarean deliveries and 1500 ml in cesarean and hysterectomy. Hysterectomy is a condition in which the uterus gets removed from the mother lady's abdomen or mother's abdomen. So that is called as hysterectomy. So there are three conditions in which once we lose 500 ml blood loss during the vaginal, second is 1000 during the cesarean, and 1500 combining cesarean and hysterectomy. But let me tell you, according to WHO, also they also have given that 500 ml blood loss if a mother loses during her vaginal birth within 24 hours of the birth, then it is called hemorrhage. But it's not a fact. It depends on the clinically, if we will try to understand the hemorrhage. So, what the fact is, if mother's hemoglobin is already 8, and if she is losing 200 ml or 300 ml of blood, and her pulse is rising and BP is falling, then also it is considered as hemorrhage. Okay, so don't get confused that when the 500 ml blood will come, then only it will be hemorrhage. No, the amount of bleeding which is causing the rise in the pulse and fall in the BP is called as hemorrhage. The next clinical definition, what I already told you. Next slide, please. Then worldwide incident. Every year, 14 million women around the world suffers with the PPH. And if we will gather the data, so sometimes we can say that maternal mortality accounting 1 in 1,000 deliveries is always killing a woman in the developing countries due to PPH. And next slide, please. Next slide. Now you can see Indian Council of Medical Research. So PPH is the leading cause of the maternal death when during the postpartum period. Postpartum period, I hope you have covered your labor classes, so you must be knowing and you must be having idea about what is postpartum period and what is antenatal period. So, PPH is a leading cause of the death among the mothers, and as per SRS, it was the survey conducted in 1998. PPH was a major cause of the death. In fact, 30% of the mothers were dying due to the PPH. So, 99% of death from PPH occurs to the person who belongs to low socioeconomic status and middle class socioeconomic status. This topic this sentence we are going to discuss later on. Okay. Next slide, please. So here you can see PPH was one of the leading cause of the maternal death, as we already discussed. And Mumtaz Mahal and star Samita Patil, you must have heard her songs and you must have watched her movies also. So these two ladies, famous ladies, were died due to PPH. Their causes are different. One is died due to atonicity, and another one died with the coagulopathy. But the reason was PPH only. Next slide, please. Now we are going to discuss about the types of PPH. There are two types of PPH. One is primary PPH and one is secondary PPH. So again, I'm repeating the same thing. You must have a little bit idea about the stages of labor. So there are four stages of labor. First stage covers from the dilatation of the cervix till full dilatation of the cervix. Okay. Second stage from the full dilatation of the cervix till the birth of the baby, and third stage from the birth of the baby till birth of the placenta, and fourth stage after the delivery of the placenta till 2 hours. Okay, so there are four stages of labor. So primary PPH includes third stage PPH and true PPH, means from the birth of the placenta till 8 hours. Okay, so it can be calculated as true PPH or third stage PPH. Secondary PPH is after 24 hours after delivery of the baby, when baby get delivered. Since then till 24 hours, it will be calculated in true PPH, but secondary PPH means after 24 hours of the delivery of the baby till 42 days, means that is postpartum period. Okay, if any bleeding occurs from or into the genital tract after 24 hours of the baby till 42 days of the labor, so it is called as secondary PPH. Now we are going to discuss about the risk factors. What are the risk factors? There are so many. So we are just going to take the names. If you will have any doubt, please let it be in comment section. I will answer you later. So as I can't hear you. So risk factors are advanced maternal age. If mother is having like age more than 35 years, she is delivering the baby after 35 years of her age, then it can cause a atonic, we will discuss the types of the PPH. So atonic PPH. Then anemia, as I already told you that if mother is anemic, her hemoglobin is already 8%, and if she is bleeding 200, 300 ml of blood, then it's a huge loss for her. So it can be calculated as PPH. Then multiparity, if mother is got pregnant so many times and her uterus will be relaxed during the birth, so uterus will not get contracted again and again, and it can cause multiparity PPH. Then multi-fetal gestation, if mother is having two twins or triplets or quadruplets and so on in her womb, so it can lead to PPH. Polyhydramnios, macrosomia, these again can cause PPH. Prolonged labor, anticoagulation therapy, if mother coagulation is not so good, so it can lead to PPH. Next, instrumental delivery, it can tear the genital tract. So obviously PPH can occur, blood will keep coming on. So it can lead to PPH. Fetal demise, chorioamnitis, means it can cause infection to the uterus, and uterine muscles will not retract back better state. So it can lead to PPH. Then placental abruption, placenta previa, fibroid, prolonged use of oxytocin and general anesthesia will relax the uterine muscles and can lead to PPH. Then there are risk factors. Next slide, please. Next, risk factors. Then atonic PPH. What is atonic PPH? Uterine fibroids, antepartum hemorrhage, and overdistension of uterus can lead to atonic PPH. What will happen during the uterine fibroid is, if this is a uterus and on the wall there is a fibroid. So after the birth of the baby and placenta, uterus has to contract and retract well in her antenatal stage. So if it this fibroid is already stuck on the wall, so that portion of the wall will not get contracted and retracted, so it will remain open, and it can lead to atonic PPH. The wall muscles will not contract and retract. And what happens, why atonicity happens, means if the uterine muscles are so relaxed, the way capillaries are between the muscles, so when the muscles will get contract, then automatically capillaries and veins will get compressed. So bleeding stops. So in atonicity, what will happen? The tone of the uterus will not remain same. Muscles will get relaxed, and these capillaries and veins will be opened, and they can flow the blood. Okay, this this is how the atonicity of uterus can lead to PPH. Got it? I hope you got some point. Then antepartum hemorrhage, again it can lead to PPH and overdistension of the uterus. When the overdistended uterus like macrosomia baby or multifetal gestation or polyhydramnios, what will happen? The uterus will get expand and overly distended. So when the baby and placenta will come out, so uterus will get confused and the muscles of the uterus will not get contract like well, and it will not stop the capillaries to flow the blood. So again, it can lead to PPH. Then prolonged labor, mismanaged third stage of labor, and retained product of conception can lead to PPH. Next slide, please. Risk factors and traumatic PPH. What will happen in traumatic PPH? Till here, we have discussed atonicity of uterus, how it causes PPH. Now we will discuss the second thing, that is traumatic PPH. In these operative deliveries, if we will insert some kind of forceps, or we are just trying to pull the baby, so and there is a small space, so what will happen if this is the genital tract? Okay, pelvis is this much narrow, and this is the genital tract. So what will happen if there is a small space? So in this small space, if the
Dear participants, madam is on having some network issues, so please wait 2 minutes. We will join as soon as possible.
Shall I start again? I'm sorry, guys. Okay. So where were we? We were discussing about the traumatic PPH. So traumatic PPH, if we will try to pull the baby from the narrow path and with the external forceps or vacuum or by other means, so what will happen? It will tear. It will create a trauma to the genital tract, and if trauma is there, then obviously bleeding will be there. Okay, so it can lead to PPH. Then episiotomy, sometimes we give episiotomy before the time. We should give episiotomy with the time, and the length of the episiotomy should be small or precise, and it should not be cut twice. One cut should be there, and we should be very perfect when we are giving the episiotomy. Okay, we should be very careful because it's a human body with whom we are dealing. So if we will do extended episiotomy, so it can lead to extra blood loss or huge blood loss. So we should be very careful while giving episiotomy, and before the time, before the crowning, when the perineum layer will get very thin, before that we should not give episiotomy at any cost. Okay, then birth of the big baby, if we will try to pull the baby and it is huge in size, so it can lead to tear to the genital tract, whether it will be the tear will be in the lower part of the uterus or cervix or in the vagina. Okay, or vaginal orifice. It can tear can be extended up to perineum also, or sometimes it can extended up to urethra also. So if it is there, so it can lead to huge blood loss. Then suboptimal conduct of the delivery should be conducted in the optimal level. Okay, the midwife, the nurse, the doctor who are going to conduct the delivery, they should be very perfect at that. And before, we should not what to say we should not experiment on our lady. Okay, then cesarean delivery. Sometime what happens, uterus will not get contracted well, or sometime they get give cut to the nearby organs also. Sometime the surgeon who is doing the cesarean section give a cut on the bladder. So it's a different thing. Sometime it happens, he or she want to give the incision on the uterus, but by mistake give an incision on the bladder or give an incision on the both of the sides. So there are chances to huge blood loss. Next slide, please. Then risk factors about the coagulation defect, placental abruption, then severe preeclampsia, in which what happens, platelet get decreased, and platelets is the one thing which helps in the coagulation. And if it is already a decreased count of the platelet in the blood level, so blood will not get coagulate, and it will lead further bleeding. Then amniotic fluid embolism, severe intravascular hemolysis, congenital or acquired coagulopathies in the mother, and sepsis or anticoagulation therapy. If patient is taking any anticoagulation therapy, like sometimes patients are put on the aspirins, so if a patient is continued till the date of the delivery, so it can lead to hemorrhage. So we should always recommend the patient, if she is taking aspirin kind of things, ecosprin and all, so before 1 month of the delivery she should stop all these things. Okay, next, there are four causes we have discussed. The one is torn. Second, four T's. You should always remember. First is torn, which causes 50% of the PPH. Second one is tissue. Tissue means the remain product of the placenta. Okay. Third one is trauma. Like if we are trying to pull the large baby, if we are trying to pull the baby without any force, or if mother is not putting efforts and we are trying to pull the baby with the help of the forceps or the vacuum, it can cause injury to the genital tract. And thrombin is a coagulopathies which mother is having already, from her it can be congenital or anything, if she is taking aspirin kind of drugs or any other anticoagulants. Okay, so there are always four T's you should remember. It can be in your exam also. So four T's: first is stone, second one is tissue, third one is trauma, and fourth one is thrombin. Next slide, please. The tone we are going to discuss, if the mother is grand multipara, means mother has given 5 or 6 or 7 births. So what will happen? Uterine muscles will get so relaxed and it will not be retracting after the delivery of the placenta. So what will happen? Atonicity of the uterus it will lead, and again PPH will be caused by it. And over distension of the uterus, as we already discussed in the multifetal gestation, in the polyhydramnios, and if the baby is large in the size, so it can lead to over distension of the uterus and malnutrition. If mother is malnutrition, mother is anemic, her blood is really less. Okay, so it can lead to PPH. Then antepartum hemorrhage can lead to PPH and prolonged labor and sometimes drug effect. Okay, then malformation of the uterus. If the uterus is anatomically it is not well formed, okay, bicornuate or sanctuate uterus is there, then what will happen? So the one side of the uterus will get contracted in bicornuate uterus, and the other side of the uterus will not get contracted, so it can lead to huge blood loss. Then uterine fibroid, we have already discussed. And then mismanagement of third stage of the labor. What is the third stage of labor? I hope you must have some idea regarding third stage of labor. It is from the birth of the baby till birth of the placenta. But what is the management of third stage of labor? There are two types of management. One is expected and one is active. So what we should do, we should not go with the, like, we can go with the expected management of the placenta, yes, of course, with the minimal handling. But sometime if the mother is on risk, because when she comes to us during her antenatal period, so that time only we screen the mother, and we try to find out if we screen and we are finding that the mother is on risk. Okay, mother is high risk pregnant, so their pregnancy, we always say high risk pregnancy. So if we find that they are high risk, then we should always go with the active management of third stage of labor. So what we should do, just after delivery of the anterior shoulder of the baby, we should give 5 units of the oxytocin on one thigh and another 5 on another thigh. Okay, anterior lateral aspect of the thigh we should always administer the pitocin. So what will happen, the placenta will get delivered very soon. Okay, so we should not do the delivery of the baby very rapidly. Needling and fiddling of the uterus should be avoided at any cost. We should always ask the mother to push down, to bear down. We should not needle, and we should not stand on the abdomen of the mother. Okay, earlier it was done, people used to needle and fiddle on the fundus of the uterus, means the midwife or somebody other than midwife also, they used to give pressure on the fundus of the mother, and what will happen, the baby will get delivered. But what will it lead? It can cause atonicity, and if you will give extra force, then there will be trauma to the genital tract. So we should avoid this. Then pulling the cord, we should always avoid excessive pulling of the cord. Sometimes what happens, cord will break down and placenta will remain inside. And what will happen, placenta will keep on bleeding like anything. It will be like open tap, and you can't save mother at any cost. So excessive pulling force should be avoided on the cord. Then manual separation of the placenta should be avoided. Then trauma. Damage to the genital tract may occur spontaneously or through the manipulations used to deliver the baby. Like any kind of excessive force while pulling the baby, while pulling the placenta should be avoided. Okay. Then trauma involves usually the cervix, vagina, and perineum. We already talked about it. Next slide, please. Tissue. So we were discussing
Dear participants, please wait 2 minutes. I think she is having some network issue. So she will join as soon as possible. We are trying to connect her.
I hope I have joined you back.
Yes, yes.
I'm really sorry, guys, for the disturbance. Next, we were discussing about tissue. So, any tissue retained inside the uterus of the mother can lead to PPH. What it will cause? It is again like fibroid of the uterus. So if any bit of the placenta remains inside, so uterus will not get contracted and retracted very well. Okay, it should retract like a ball. Where after the delivery of the baby and the placenta, uterus should be like a ball. It should be very hard. But if a bit, a small 1 or 2 centimeter bit of the placenta remains inside, it will not let the uterine muscles to contract well. So what will happen? Atonicity and again PPH. Okay. So when you will deliver the placenta, you should examine the placenta very well. Okay. There should not be more holes than one. Okay. There should be only one hole in the placenta. Okay, so through which the baby will come out. If there are too many holes, if the placenta is not complete, it means it is suggestive of that some part of the placenta or membrane is still inside the womb of the mother. So it should not remain. If it is remaining, then it can lead to PPH. And sometimes what happens if a 1 centimeter clot is there inside the uterus and uterus is contracted well, so what will happen? It will cause infection, sepsis to the mother, chorioamnitis to the mother. Okay, it can again lead to secondary PPH. So you should be very careful while delivering the placenta. Next slide, please. There are three phases involved in the normal expulsion of the placenta. First is separation through the spongy layer. When the separation is there, when separation occurs, separation between what? Separation between uterine muscles and separation between the placenta. Okay, this is the placenta, this is the uterine muscles. It get attached like this. So when the separation occurs, okay, means placenta gets separated from the uterus, uterine wall, then what we should do? It will automatically come to the lower segment of the uterus. Okay, then it should be expelled with a control cord traction. We should give a like same force throughout the delivery of the placenta. Okay, the cord should be controlled and tractive. Okay, we should extract the cord with a same force. Okay, so control cord traction, we should give a traction, like we should pull the cord in a same manner. We should not like this time we are losing the cord and again we are pulling it hard. So what it will lead, sometime the cord will get torn up, it will lead to bleeding, and sometimes part of the placenta will remain inside. Okay, so we don't need to put excessive force on the cord. Okay, so control cord traction should be there. Next slide, please. Then interference in any of the physiological process results in the retention. All yes, of course, if we will pull the cord, we will put the excessive force, then automatically placental bits will remain and it can lead to placenta like tissue PPH. Next slide, please. Thrombin. Blood coagulation disorders are less common in causing PPH, but of course, it leads like 2 to 3% of PPH, like idiopathic thrombocytopenia, hemophilia, and whole Willebrand's disease. Okay, next slide, please. Now we will discuss about the secondary PPH. Bleeding usually occurs between 8 to 14 days of the delivery, but it can lead up to the 42 days, okay, during the postpartum period. If any bleeding which is raising the mother's pulse and falling the BP down, it can lead to PPH, okay. Then retained bits of cotyledons or membranes, as we already discussed, can lead to PPH. Then infection in the separation of slug or a deep cervicovaginal laceration. What happens sometimes? Vaginal laceration, हमारा anterior part of the vagina, okay, the pouch of Douglas. Sometimes it get torn up, okay, and initially it get healed, but sometimes infection occurs over there. So if there is any kind of infection and it is not managed well, So it can lead to PPH. It will not, there will not be huge bleeding, but there will be a bleeding which will be for a long time. Again, suppose within 5 minutes I'm losing 500 ml of blood. This is also PPH, and if over 2 or 3 weeks daily I'm like losing 50 or 100 ml of blood, it is also PPH because mother's blood level is coming down. So it is PPH. Okay. I hope you got some point. Next slide, please. Clinical features of the secondary PPH. There can be vaginal bleeding. Okay. Prolonged vaginal bleeding. Mother will get paler. Mother's pulse will get raised. BP will be fall, and there will be sometime altered level of consciousness. Okay. Next slide, please. Now it's the time how we will diagnose whether it is PPH or not. Okay, how we will diagnose? First, we will see the mother's pre-hemoglobin level. Suppose we have not have any idea about the mother's pre-hemoglobin level, means before delivery. If it was 8 and after delivery we found 7, then it's okay. Then it's really okay. Okay, and if mother's hemoglobin was 13 and after the delivery we find it 8, then it's not okay, it's hemorrhage, it's PPH. Mother has lost huge amount that her body cannot compensate now. Okay, so we need to give excessive other body fluids, or like body fluids include fluid, or platelets, or coagulation factors to the mother, or IV fluids. Okay, then degree of the pregnancy induced hypervolemia. Okay, obviously when mother gets pregnant, so her blood volume get increased. Okay, because she has to nourish her baby also. So we should find out the degree of the pregnancy induced hypervolemia, how much mother is holding her fluid level, and after that how much dehydrated she is. Okay, how much blood loss she has. Then next is speed at which the blood loss occurs. We should monitor the speed. Like within 1 minute, it is like how a tap is open and water is flowing. It is same like that, or it is just keep on coming at a normal pace. Or and don't get confused when the placenta get detached. There will be a blood. Okay, gush of blood will come. So placenta, when it gets detached from the uterus, there is a gush of blood. Okay, so don't get confused between PPH and gush of blood after separation of the placenta. If the blood is coming with the separation of the placenta, then it's okay. But there is a some amount. Okay, it will be 15 ml to 50 ml to 100 ml, not more than that. Okay, so don't get confused, guys. So three things we should find out: pre-delivery hemoglobin, then hypovolemia state of the patient, and speed at which the blood is losing. The next is examination. We should palpate the uterus. If it is contracted and is still bleeding, it means there is a traumatic hemorrhage. If uterus is saggy, flabby, okay, then it is hemorrhage is due to atonicity. Means mother's uterus has not attained the tone, so because of that, it is bleeding. Next slide, please. Then management of PPH. How we will manage the PPH? First is recognition. First, we should find out whether it is really PPH or it is a gush of blood which comes with following the delivery of the placenta. So first we need to find out what is it. Then yes, if it is PPH, then we should recognize from where the blood is coming. Is it due to atonicity? Is it due to trauma? Is it due to tissue? And if the three causes are not there, then before taking the patient for the delivery, you should always ensure about the documentation of the patient. You should always go through with the documents whether any leading cause is there. What about the platelet count of the patient? Patient PT INR and PT TK. Okay. Then patient is not on any anticoagulant therapy. This you should be very sure. Okay. So if you are very sure about her PT level, her PTTK level, her INR level, her platelets level, and she is not taking any anticoagulant therapy, then it's fine. And if you still find that there are patient uterus is well contracted, there is no bleeding from the genital tract, Okay, there is no trauma and there is no tissue left inside. When you taken out the placenta, you have examined, and placenta is with one hole and a complete maternal site, and there is no retained product of the placenta or membrane inside the wound. So it can lead be fourth cause. So what you need to do is give injection vitamin K 10 mg instantly to the patient. Okay, or give injection tranexamic acid 1 gram to the patient. So it will minimize the bleeding. It will minimize the bleeding. It will help you to think. Okay. So after that, you can take second step. Then recognition. You have recognized the patient. Then what you should do next? Communication. You should shout for help. First, you should shout for help. Okay. You need some person who will call the doctor, who will call the other person, who will call the OT person to get OT ready, who will call to the blood bank person to get the blood ready. Okay. And make sure before inducing or before taking the patient on the table for delivery, you will always send take one sample for blood demand. Okay. If in case you land up with the PPH, so at least that sample will help you out. You will send that automatically to the blood bank, and you will within no time you will get the blood to replace. Okay. Then resuscitation. Try to resuscitate the patient. Means put the large bore IV cannulas and rush the IV fluids. Rush the tranexamic acid in the IV fluids. Then give our injection vitamin K. So such kind of resuscitation you should try to do. Then monitor and investigation. Then you monitor the patient and investigate what is actually happening with the patient, and then direct it to the phone. Next, next slide, please. Next slide, please. This is how you will estimate the blood loss. Okay. These are the pads which we are using in army setup. These are the pads which we are using in army setup to find out how much blood loss it is. So in your setup also, in your organization also, you must have some pads. So it can tell you about like how much blood loss mother has done till now. Okay. Mother has had till now. Okay. So with the glance at a pad, you can find out. Next is management of PPH. Sorry, directed treatment of PPH. Management of third stage of labor. How will you manage third stage of labor? First, you will control the fundus. Then you will massage the fundus and make it hard. Okay, after the delivery, what will you do? You will control the fundus and you will massage to make it hard. Okay, what will happen when you will massage the fundus of the uterus? What will happen? It release oxytocin. Okay, so already oxytocin is there in your means in mother's blood. So what will it cause? It will increase the amount of the oxytocin which will contract the uterus. Okay, massage the uterus first. Second, give injection methazine 0.2 mg IV, or IV if you are going giving in slow IV, and or IM also you can give. Then you can give 20 units of pitocin in 500 ml of NS. Then arrange for blood transfusion. Catheterize the patient. Sometime what happens if bladder is full, it will not let the uterus to get contracted well. Okay, so catheterize the patient. Urine will come out and uterus will get contracted. It will get space to get contracted. Okay, if the placenta is separated, then examine the placenta. Okay, and if placenta is not separated, then try to remove the placenta under the general anesthesia. Next slide, please. This is control cord traction, how we do deliver the placenta. We will give a counter pressure. We will not let the uterus to come out with the placenta. If we will put extra efforts and extra force, then uterus will come out with the placenta because it is already attached with the placenta. Okay, so no need to give extra force, no need to put extra force on the cord. What you need to do is put the hand on the just above the pubic of the mother and hold the uterus in opposite manner, and then you pull. Okay, give a counter pressure. Okay, next, manual removal of the placenta. This is how we should remove the placenta manually, but it should be under general anesthesia because patient is going to have huge pain. Okay, then next slide, please. Torn. Uterine atonicity is the most common cause of primary PPH, but clinical assessment should be excluded to other causes. Okay. Next slide, please. Intervention. What we need to do is we can do massage. Two types of massage we can do. One is internal massage. We are just going to put our hand, insert our hand through her vagina to internal, and we will just try to give the massage. Second, outer massage. First thing after delivery of the placenta, we should give outer massage on the fundus. If uterus is not good, get contracted, then we will put our next hand inside the vagina, and we will try to massage from the both of the ends. Okay, in this manner, we will massage the uterus so it will get contracted. If it is not good, get contracted, then also, then we will pull the like we will put the extra force on the uterus, both walls of the uterus. So what will happen? At least bleeding will get stopped till the time. Okay, and you will get time to think wisely what to be done next. Next slide, please. If the massage is not helping, then go with the drugs, which is pitocin. 5 units, slow IV directly you can push if you are finding that mother is having PPH, or up you can go up to 40 units, but more than 40 units you cannot go. If you will go more than 40 units, then it will lead water intoxication in the mother. Okay, so maximum doses of the pitocin is 40 units in one delivery. Okay, then other than pitocin, if it is not controlling by pitocin, then you can go with methergine. Methergine you can give 2 mg now, then you can repeat after 1 hour, then you can repeat after 1 hour. Then misoprost 1000 mcg you can give per rectal to the mother, and carboprost injection you can give 25 mg. Okay, but carboprost you can repeat every 15 minutes. In every 15 minutes you can repeat the carboprost. The side effect of the carboprost is mother will pass the stool. Okay, so be careful while administering the drugs to the mother. And these four medication at one time can be given to the mother if mother is in PPH. Then trauma to the genital tract. Next slide, please. We should make a thorough assessment to the genital tract. If there is any trauma, then we should try to suture it. If we are unable to suture it, then we should send the patient immediately to the OT. There, under the general anesthesia, we will examine the patient and we can try to rectify it, repair it. Next slide, please. Next slide, please. Okay, tissue. We should find out, yes, tissue. We should examine the placenta very carefully. There should not be any left bit of the placenta or the membrane or the cord inside the mother's womb. Otherwise, it can lead to primary or secondary PPH. Next slide, please. If there are thrombin abnormalities you are finding during the examination or during the documentation of the patient, then as we already discussed, injection tranexamic acid 1 gram you should give to the patient. So at least it will relieve somewhere. You you also can think it will give you time. Okay, it will control the bleeding then and there, and you will get like little bit of time to act upon it. Okay, so ऐसा नहीं है कि if you have given tranexamic acid, so blood has stopped and you don't need to inform further. No, you have given tranexamic acid. It's good thing you have saved the mother from the PPH and sometime mortality also. So you need to give tranexamic injection tranexamic acid, and call to your doctor or physician or whosoever is available in your emergency department or wherever, and call them meanwhile. Okay, and inform that you have given injection. Until this time, you can save the mother, and then try to find out the cause, exact cause, and deal accordingly, manage accordingly. Then replacement of platelets and clotting factor, as I already told you that before taking the patient on the delivery table, you should always take one sample for blood matching. So if mother is in PPH, so directly what you can do, you can send the that blood sample to the blood bank, and you can get the platelets or other clotting factors, and you can start. Okay, sometimes blood also will do well. Next slide, please. In theater, what we do before uh, sending the patient to the operation theater, what we do sometimes is we to try to give condom catheterization to the patient or balloon catheterization to the patient. Means we are just going to put one balloon inside the uterus of the mother and we keep on inflating with the water. So it will give a pressure on the uterine wall and it will not lead any further bleeding. Okay. Next slide, please. Baleen suturing can be done. It can be done only on and only in theater just to prevent the bleeding. Next slide, please. Bilateral ligation of the uterine arteries can be done to save the patient. Means uterus is the main cause from where the bleeding is coming. So if we ligate the both side of the arteries of the uterus, so blood flow will not be there and there will be no blood. Okay. So bilateral ligation will do better. Next slide, please. Bilateral ligation of internal iliac arteries. It is again good management of PPH. It can be done, but again, it is also in operation theatre. Next slide, please. Next slide, please. Or if after ligation of the arteries also it is the blood is not controlled and you are finding that mother is going out of your hand and she may die. So what you need to do is hysterectomy. Just take out the uterus out. Okay. So after that you will be able to manage. Then secondary PPH, how it occurs. We have already discussed. So how we are going to manage is antibiotic therapy, uterotonics, and surgical interventions. Antibiotic, if it is due to sepsis, if it is due to chorioamnitis, if it is due to like retained product of the beads infection, then we will start patient on the antibiotics. If the maternal uterus get relaxed again and it is not contracting well, then we can start patient on the uterotonics. And if both the things are not helping, we are going to take the patient for the surgical intervention. Next slide, please. The algorithm for the PPH is hemostasis. Our goal in PPH is hemostasis, and the algorithm is also hemostasis. So you just need to, if it is coming in your exam, so you just need to remember hemostasis because other things you know, definition you know, any blood loss in from and into the genital tract, which is leading the maternal health variable, then her normal health is PPH. Okay. Then causes, you know, what are the causes? Then 40s. Then now we are going to deal with the management. That is hemostasis. Hemostasis, what will you do? H for help. Ask for help. A for assess. Assess for the vitals of the mother. E for etiology. Find out the etiology from where the blood is coming, whether it is due to atonicity, whether due to trauma, whether it is due to thrombin, or whether it is due to tissue. Okay. Then find out the cause. Then M for massage. Massage the uterus. Try to massage the uterus immediately. Then O for oxytocin. Try to give injections. First start with the oxytocin, then give methargine, then misoprost, and then go with the carboprost. Okay. Next is S is shift the patient to the surgical room. If it is not helping you out, just put the anti-shock garments. It is always available in every hospital. In medical military setup we do have. In your institution you must have had anti-shock garments. What it is just type of jacket and pant. Okay, you can put the patient, it can be opened up like this. You can put the patient on that and you can inflate. So what will happen, from your periphery, means from your hands and legs, from your peripheral, the blood will be minimized and it will be supplied to your central organs, vital organs. Okay, so mother will not be in shock if you will put in the anti-shock garments. But till some time, if mother is continuously losing, so it will not help much. But yes, of course, in like mild form, moderate, it will really help you. Then shift the patient to the operation theater. Then T4, tissue and trauma to be excluded. Proceed for balloon tamponade or balloon catheterization. Okay. Then A4, apply the compression or suture the, either apply the compression on the bimanual compression on the uterus or suture the uterus. Okay. Then S4, systemic pelvic devascularization. What we have seen now, that both lateral means bilateral iliac arteries or uterine arteries we can ligate. So it will come in the systemic pelvic ligation. Okay. Then I means intervention you should do. Then S is subtotal or total abdominal hysterectomy we will do. Okay. So you just need to remember the hemostasis, ask for help, assess the vitals, find the etiology, massage the uterus, oxytocin or other drugs, shift the patient to the operating room, find balloon tamponade, then apply the pressure or apply the sutures and devascularization of the arteries, and intervention other than that you can do to the patient, and subtotal or total abdominal hysterectomy you can do. Next slide, please. Measures of prevention of PPH. How will you do? During her antenatal period, take the detailed history, assess the risk, okay? Do the blood investigations. During the ultrasound, localize the anatomical, any anatomical defect in the uterus or size of the baby, and multiple fetal gestation is there. Find out such kind of things. Okay. Then notice the cervical length. Okay. All these you should find out on the USG. Then improve the health status during the antenatal period, means you will advise the mother to take the green leafy vegetables, improve her blood, then her platelet count should be good. Then you will advise the mother, and she should be mentally prepared for the delivery. Okay. Next slide, please. During her internatal phase, what you need to do is proper perineal support should be given while delivering the baby vaginally. So there should not be any laceration to the perineum. Otherwise, what will happen? The like tear will be from the perineum till the anus. So it can lead huge hemorrhage. Then timing of episiotomy, what we have already discussed, should be very concise, and you should be very careful while giving episiotomy. Then pharmacological action should be taken on time. Then delivery of the placenta should be with always controlled cord fraction. And if you are delivering the placenta, then always go with the advanced method. Okay, and don't go with the expected management of the labor. The next is examination of the placenta. Next slide, please. Examination of the placenta should be done. Then you should ensure all the action has been taken towards hemostasis. Okay. Hemostatically, mother should be managed well. Then observe the patient for 2 hours just in labor room. Then only you can shift the patient to the normal wards. Next slide, please. Complications of PPH. What it can be? It can be shock, DIC, uterine inversion. If you will put extra force, you will pull the cord. So uterine inversion can be there, and subinvolution of the uterus, embolism, and infection. Okay. Next slide, please. If you want to watch mock drill, we have taken. I feel I really don't know whether it will be played. Ma'am, try to play, please, if it can be done from your part. Okay. So conclusion: what we need to do is, first, mother should be well prepared for the delivery during her 9 months. Okay, we have got enough time, more than enough time. 9 months are enough to prepare a mother for a delivery. Okay, psychologically, physically, mentally, socially, economically. Okay, so we should prepare the mother in every aspect. Then competent staff, the handlers who are going to conduct the delivery, who are going to handle the baby, who are going to handle the mother and the baby, the handlers who is handling it can be Didi, who is working with us, our assistants. It can be nursing officer, it can be medical officer, it can be your mm, trainees, and it can be your doctors. Okay, so senior residents and all. So they should be very competent, and they should be very calm enough, because if they will get panic, if one will get panic in the team, the whole thing is going to spoiled. Okay, so very competent staff who is not get panic during the delivery. And if pph occurs, then also we should not get panic. In a very calm mind we should act, we should know what is next, what should be next. So competent staff is must. Then effective emergency response system should be there. There should be quad blue system. So if any emergency is there, so you will just make a call, code blue active, as in our military setup we do have code blue system. If any emergency occurs, what we do is we give a call on a particular number, and we just say code blue activated. So what the code blue team has to do next, they will get activated, they have their setup, they have their trolleys, they have their crash cart. They will pull the crash cart, they will take the trolley along with them, and they will reach to the station where the help is required. Okay, and within 15 within 2 minutes, means 15 seconds to 2 minutes, they should reach to the spot. Okay, so emergency response system should be activated, and it's a teamwork. Your team must be very good, and you should be very cooperative to each other. So thank you, I have completed my teaching class with you. So guys, if you have any query or anything, just leave it in comments, so I'll answer, or I'll try to answer you guys. So about military, I
Yes,
already
I
promised
think.
you that I'll tell about the military to you. It's yes, of course, force is a better organization, and we feel so good when we serve in our army. Why? Because we are serving, who are serving to the nation, like Fauji, who are not Fauji. Okay, they are serving to the nation, but we guys are serving to them, who are serving to the nation. So just imagine how beautiful this thing will be, and I am really enjoying this duty. Yes, of course, sometime it's a hectic, because 24 into 7 we are always on duty. Sometimes we are on leave, but we get a call from our organization that we really require you, we need you. Just come back, join after means join from the leave immediately. So yes, of course, there are always pros and cons of the services, but I really enjoy this service, and I always feel pride, and not only on this service, not only on me, and not on these ranks which I'm wearing on my shoulders. Yes, of course, it is giving me pleasure, but I'm always proud on Pannadhai Subharti Nursing College, because I am got my BSc and MSc done from there, and I'm always paying my gratitude to our principal ma'am, Madam Geeta Parvanda. She is an amazing mentor, and guys, you just listen to her, and she'll guide you in a better way, and you will shine like a star. So if you wanna join Forge, there will be vacancy will be released in month of, I feel, January. It is only and only for girls. We have already put up the case in military also, that we are going to take the boys also, but that case is still pending. So till now we are taking the female officers only, and this is only the core. This is only the core which is completely led by the female. Okay, this is for this time we are going to have a parade on 26th January also. So on 26th January also you will find the officers in same uniform on parade also. So it's an amazing experience to work in the army. So if you wanna join, so with I wanna say my girls that they can fill their exam forms in month of January. I think it will be released, or I'll intimate ma'am when it will be released, so they can fill their forms. They can prepare for interview, and then your medical test. And if you will clear all the three things, then yes, of course, you will be an officer of Indian Army. Thank you so much. Jai Hind.
Thank you, Neha. Thank you so much for giving your time in your busy schedule. So I'm requesting to participants, if you have any doubts, you can ask or write in chat box. Then we will clear your doubts. So you can write your doubts in chat box. We will ask to madam and we will clear your doubts. And thank you, Neha, that you share your experience in military hospital, or as you share your burden. Then I would like to thank to our principal madam, Dr. Geeta Parvanda, to give this opportunity to organize the alumni speak. This is our 13th alumni speak, and we are planning by next month also we are going to do the 14th alumni speak. Then I request to all, please cooperate with us, and I request to all alumni, those who are listening and those who are watching this webinar. So please, I request you, then you can also participate and you can also be a resource person to do this webinar. Thank you so much, and thank you, Neha, Captain Neha, once again to giving us your valuable time. I know you are very busy with your work, so thank you so much.
Thank you, ma'am.
Thank you.